Perfect.
you, Dr. Hartzell.
So I feel like
Oh,
we can go ahead and get started. I think most of us are here.
okay, great. Hello, everyone.
Thank you so much for doing that presentation. We need it.
Oh, you're welcome. It's you know, thinking about this and trying to put it together. It's a big topic. There's a lot to think about. Um, but anyway, I just try to give you some hints and tips, and we'll look at a lot of examples. Um, and like I want this to we'll make it interactive, particularly when we start looking at cases. I want to kind of have you guys kind of weigh in and see what kind of grading you would give to dysplastic lesions and that kind of stuff. But just there's a little background. I thought, kind of this is like my background a little bit of on this topic. So let me just kind of go through a few things quickly here at the beginning, just as like overview stuff. Okay, you guys should be able to see my screen. Yeah.
Yeah, we can see
Any
it.
good. Okay. So, patients that have dysplasia, it's almost always oral cavity and larynx. Doesn't have to be isolated there, but it usually is, and particularly true chords, so glottic larynx, and then oral cavity. Lots of different sites where we see precancer lesions, and they will present because patients have leukoplakia, erythroplakia, or they're being followed for another cancer and develop lesions later on. And they don't have a lot of tools to treat these patients. They can cut them out, you can watch them closely, but they don't really have chemo prevention. There's no oral medications, there's no swish and swallow. I mean, these are kind of the holy grail of oral, particularly oral dysplasia, but they don't have anything. So mostly they are just going to follow them closely, cut out what they can when they can without as much, with the minimal morbidity. And if they're smokers or drinkers or other things, and try to get them to stop doing whatever may have lended to them developing it. Um, I often refer back to the Blue Book, the WHO Blue Book. Particularly, there's a section in oral cavity, a section in larynx on precancerous lesions in there that I think is helpful. There's images. There's also some whole slide images. I think if you want to do a deep dive into this and you want to really look at the cytologic and architectural features in detail, that paper I shared to Esther, the Hankinson paper that is listed here, Demystifying Oral Epithelial Dysplasia Histologic Guide. So you have to have a catchy title. But anyway, it's a very, very good article. It's a bit detailed. There's also whole slide images you can link to at the end if you want to see examples of some of these features. We'll cover a lot of them, but there are a lot of histologic features of dysplasia versus normal and reactive. So it's kind of that's partly what the problem is with dysplasia anyway, and with the grading. So we'll talk a little bit about normal. I'll show you some examples of normal at the start, kind of normal mucosa and different sites in the oral cavity and larynx. And then in terms of grading, well, I'm a three-tiered guy. I always have been. There's a big push to simplify it into two tiers, low grade, high grade. And this has gotten bounced around over the years. The more recent WHO Blue Book version of it, they allow for sort of both systems. And I'm torn about it because there's this intermediate category in between mild and severe that frankly is hard to predict how it's going to do and what the risk of progression is. And I just think logically it makes more sense to have something in the middle because I think that's the truth of it. And trying to push the middle category into lower high grade all the time gives you more inter-observer variability in that. And I'm not sure it's clarifying risk of those lesions, for the patients and the doctors who are trying to manage them. I've kind of done this hybrid version where I do mild dysplasia and I put parenthesis low grade, moderate dysplasia, parenthesis high grade, severe high grade, as you can see. Squamous cell carcinoma in situ is a little bit different. I don't use that terminology often, and really the The blue book will tell you that these two are basically synonymous in terms of risk of progression. And so they don't even recommend you calling squamous cell carcinoma in situ. There are certain scenarios when I use it, and we'll talk about that. Mostly just because it gives some bells and whistles. You know, if something's really, really very florid, but it's not invasive, I may want to flag it as squamous cell carcinoma in situ. But I think of those two as being synonymous in terms of their risk of subsequent cancer. Okay. And then there's the 1/3, 2/3 full thickness system, you know, like that we've extrapolated from cervical dysplasia and from other anatomic sites. And as you all know, in head and neck, that kind of falls apart a little bit. Certainly, if something is into the middle third of the epithelium or is full thickness, that's not a good sign and probably is indicative of high-grade dysplasia. But lots of examples have, you know, the action limited to the lower third and are still severe dysplasia, particularly keratinizing dysplasias, and those are the ones that are kind of scary and difficult. But this is kind of the terminology I've been using out here to kind of wed the low grade, high grade that they've been doing, and lots of other people have been doing, but I have not left kind of having moderate dysplasia. I think the other thing is that at Vanderbilt, typically, if we said moderate dysplasia in the margin on a frozen, they wouldn't do anything more, right? What they wanted to hear was severe dysplasia. They would usually go and cut more, and everything else they would leave it, whether no dysplasia or mild and moderate. So we wouldn't really grade it. We'd just kind of say negative for severe dysplasia or carcinoma in the frozen, and that usually was enough. Here it varies a little bit. We haven't run into a lot of scenarios where it was looking moderate in the margin, but if I'm at all worried it could be severe dysplasia in those margins, I'll flag it at least for them and have a discussion with them. But generally, that's, you know, the low grade, high grade is kind of where decisions are usually made. The low grade or mild, you know, they don't do anything surgically if it's in the margin, and those are the lower risk lesions. The other couple things to say at the beginning here, and then we'll look at some slides, is that, you know, this dysplasia system is for flat dysplasias, okay? It's not really extrapolatable, if that's a word, to verrucous and papillary lesions. You can't extrapolate it to recurrent respiratory papilloma, ptosis papillomas. It just doesn't translate very well to other kind of precancer lesions, much as we might like to try to utilize the cutoffs and the features that we talk about here. And then the progression rates are highly variable, and the grading is, there's a lot of inter-observer variability because there's so many features, and there's no like quantitative system where you have too much of one and another that it qualifies as this. It's just kind of a little bit of a gestalt. Progression rates vary. If you just have leukoplakia, hyperkeratosis with no dysplasia, the risk of cancer is something like 1%. I mean, it's in that range. Whereas mild dysplasia, it's probably 1 to 3%. So it's not that much different. If you have leukoplakia and no reason for it, then you probably have a precancer lesion, particularly in the oral cavity and in the true chords. Moderate bounces around depending on the study. But it's probably something like 5%-ish. And then severe is, you know, probably 15, maybe 20% lifetime risk of progression to invasive squamous cell carcinoma. But it's not super, super high. And people would say that strictly defined carcinoma in situ has a higher progression risk even than that. But it's not clear because the definitions of what are those two things are not consistent. Okay. Questions or comments at this point before we kind of look at some examples? Yeah. Okay. How about some normal? Let's look at just some normal, and we'll kind of do normal and talk a little bit about what normal should look like, and, you know, what the actual cells in the epithelium should look like in normal. Okay, so let's just share my screen again. Where did we go? Hold on, sorry. Okay, oral cavity. Okay, this is the mandible, inferior alveolar nerve, and we've got gingiva. Okay, here's the normal gingiva. Okay, it has a fibrous submucosa, and it has a little bit of keratin, not a lot. Classically, you don't think of having a frank keratin layer in the gingiva. Hard palate usually does. But you see these thin, kind of strandy, interconnected reedy with very small basal cells, no mitotic activity. And I mean, there's some plumper nuclei here, but it's not, they're not particularly atypical. They mature up and flatten out. So this is your normal, okay? So that's normal gingiva, okay? But it's normally going to be very pointy and kind of strandy like that, okay? Actually, let's not do larynx yet. All right, this is floor of mouth, okay? You can see Wharton's duct there, part of it. And then this is a little bit probably of sublingual gland. You can see some skeletal muscle. And the floor of the mouth also does not have a keratin layer, so we don't see keratin up here, right? And then you can see it's relatively flat reedy, and the basal cells are very small, very dark, and not proliferating, okay? So that's kind of your baseline normal floor of mouth. It's relatively thin epithelium, okay? All right. Keep trucking along with some normal here. Here's buccal mucosa. Buccal mucosa is a little bit thicker. Okay, usually have fat. Sometimes you'll get some salivary gland tissue, some muscle under there. So it's a little bit thicker, but again, does not have an actual keratin layer on the surface. Okay, unless it's traumatized. And the basal aspect is again pretty small and inactive, but thicker. Okay, and people talk about how thick the epithelium is, that you can kind of use that to tell if something is too thick or not. I haven't found that useful to me in oral lesions because I can't often remember how thick the epithelium should be and number of cell layers, and it's a bit tricky to count. But I do keep in mind that some areas of the mucosa are thicker and have certain attributes to them. So this is the oral tongue, okay? Cross section. So this is lateral, ventral, okay? And then coming up on the dorsal tongue. The dorsal tongue, or action tongue, I call it, is very thick and very undulating and usually has a lot of keratin on the surface, often has hypergranulosis or, granules in there, bacteria on there. But again, the basal layer down there, look at these, how small and inactive these basal cells are, okay? And usually don't see mitoses, so they're not usually proliferating. That's normal dorsal tongue. We kind of come over, and then you start to get onto the lateral tongue, which is one of the most common sites of oral cavity squamous neoplasia, and you can see there's no keratin layer, and again, a very inactive kind of basal cell, and it thins out, right? And then we'd be coming down, and this would connect to the floor of the mouth. Okay, let me see what else I got here. A couple more things. Last one, I think, that we'll show, and then we'll do larynx. One thing that gets people into trouble is when you get to the posterior tongue, as it transitions towards the base of the tongue, the epithelium thins out, and it's not your usual dorsal tongue. It's kind of thinning out, and you start to get taste buds, okay? So these are taste buds. This is like olfactory neural tissue from taste buds, and it's particularly kind of weird looking and different looking kind of spindly stuff. It forms these rounded nodules, and the epithelium really thins out, okay, around it. And these little onion bulb guys in here are gustatory cells, okay? So those are little taste buds in there associated with that. Don't be confused by the tongue thinning out on a small biopsy and not maturing up as much, because this is just what it does over and around these taste buds, okay, as you get to the posterior oral tongue. So sometimes you'll get a small biopsy of the posterior tongue and it looks like this, and you're like, whoa, it should look like this, but it looks like this. Maybe that's dysplastic, but it may just be that you're sampling this epithelium. Okay, and then we do larynx. Let me see where my larynx one is. Oh, got a lot of screens open. There it is. You guys stop me with questions or comments. Okay, and then the larynx. Okay, this is the false fold or false cord has seromucinous glands in there. It's usually lined by respiratory epithelium, the ventricle, the true cord with the vocalis muscle, Ranke space, which is the connective tissue in there. And the normal cords are always squamous, okay? They're not respiratory. And this is what they look like, kind of a medium thickness, no keratin on there, and then an active basal cell layer. Okay, so that's what we're looking at. Now, when respiratory epithelium kind of transitions over to squamous, you may get immature squamous. And people screw this up all the time as dysplasia, particularly on frozens. There's no proliferation in this, and it's super flat, okay? So this is transitioning from respiratory type over to squamous. Okay, so it's immature squamous. It's not dysplastic. If this were dysplastic, it would be less regular in thickness. It would have apoptosis and mitosis, and it would have abnormal keratin. We just don't see dysplasias that look like this in the head and neck very often. Okay, so keep that in mind. Okay, good. And I thought we'd just go through, I've got a whole bunch of dysplasias, and I thought maybe we can just kind of go through and look at them, talk about the features, and kind of grade them together. Yeah? That
Sounds
sound
good.
all right? Cool. When you're presenting, you can't see, like, I guess I can change my little thing to see you guys. Yeah, there we go. Put it on my other screen. Okay, so why is dysplasia grading so difficult? Because look, here's 28 architectural and cytoplasmic, or excuse me, cytologic features of dysplasia, okay? And they don't have any, like, grading of them or weighting of them. I mean, they all are potentially important, okay? So, like, take a human being and ask them to categorize something with a minimum of 28 variables into 3 categories using all of those. Yeah, you kind of expect you're going to have some trouble. But anyway, these are very good, and these are all features that we tend to use in looking at them to various extents. And I'll just kind of show you the ones I key on that I think are the most important. Okay, so let's just start with one here. See if I can switch this around. Uh-oh, lost it. I'm trying to get that thing. There we go. Okay. This actually is floor of mouth. It's very superficial, though. Let's see if we go over here. By the way, I don't have a lot of jokes, but the one joke I have is I was sitting and looking at an oral dysplasia case with an otolaryngology resident one day. And it was great because I was going on and on about how the epithelium, look at it, it was disorganized, it's growing uncontrollably, and it shows a lack of maturation. And she said, wow, that sounds like the average teenager, which I thought was pretty good. So I like to think of these dysplasias like a disorganized teenager. Anyway, okay. Now, a couple things to notice. The epithelium's a little bit thick. There is some parakeratosis. Okay, I don't make a big deal out of para or orthokeratosis in these lesions. It doesn't tend to matter much. It's thick, but it's clearly maturing, right? Like, it's very thin out here. Okay, very small nuclei up here. But if you look at the base of this thing, you can see some problems, right? First is, instead of being that really dark single layer of hyperchromatic nuclei with scant cytoplasm, the nuclei here are pretty revved up. They're bigger in the mid layers, okay? And they almost palisade. If I see it almost palisading, then I'm almost always at dysplasia. If there's nothing else going on, that usually is a feature of dysplasia. And then the other thing about this one is that the reedy pattern is a little bit abnormal, right? We're starting to get some expansion of the reedy. And then, is there mitotic activity? Yeah, there's some, but it's not too striking, okay? I'm not happy here. This is starting to be almost a little bulbous. We call bulbous reedy, where the neck of the thing is narrower than the base of it, so it starts to look kind of teardroppy. So I'm not too happy with that either, but there's a lot of maturing differentiation here. There's not a lot of mitotic activity. So it's a keratinizing, and there's no reason for this to be doing this. There's nothing for reactive. So I'm kind of like, this is one of those where I think probably low grade or mild, but it's pushing it a bit there. But you'd be hard pressed without more of architectural abnormalities to really call this, moderate or severe dysplasia. So I'd probably leave that one at low grade or mild. I mean, mild, and I would put parenthesis low grade. Okay, so let's do another one. Let me see.
So I have 2 follow-up questions to that.
Yep,
The first follow-up question I have is, the bulbous reedy are solely a dysplastic feature, right? Like you cannot get that in a reactive condition.
Right. You basically just don't get that.
Okay.
And particularly if they are filled, I like to see them, the really bad ones are filled with dark cells. They have higher NC ratio and bigger nuclei. They tend to look blue. So they're bulbous and they're blue. That's particularly bad. If they're bulbous, but they still have a fair amount of pink, that's a little bit more reassuring. And we'll see some examples of that. But yeah, bulbous reedy is almost synonymous with dysplasia.
Okay, perfect. And then one problem I have is that when I identify bulbous reedy, but then I'm trying to think of like how I'm going to grade it. And you mentioned, it doesn't have like any of, or the previous case, it didn't have any of the cytologic features of like a higher grade dysplasia. So if I'm understanding it correctly, you kind of want there to be at least some cytologic features to get you out of benign. Architectural features alone are not going to get you, or not benign, out of the mild category. Architectural features themselves aren't going to get you out of the mild category.
Well, no, you can, but you usually don't have them in isolation.
Okay.
Yeah. In theory, yes, you could get to high grade without much cytologic features, but you almost always have them in combination with architectural features. So in theory, yes, but in practice, almost never does that happen.
Okay.
All right, so that one was kind of pushing it, but I probably leave it as mild or low grade. Okay. Here's another one, some superficial, and these are superficial. So sometimes, you want to put a comment as superficial or minimal stroma present, particularly if it's a severe lesion, you may be missing something that they didn't sample underneath. All
I have
right.
a quick question on the other lesion. Is there real management differences between like a mild and a reactive? If you call this, let's say, severe reactive or something, would the management be different?
Yeah, because presumably it's reacting to something, and they'd like to figure out what that is and treat it. Because that should fix the problem. The other is that reactive dysplasia implies risk, and reactive usually there's inflammation, usually there's other reasons going on, or there's this trauma or something else going on, but it's going to flag in the doctor's mind reactive, right? Self-limited, going to go away, shouldn't be a risk long term. So yeah. And I think here, like, you could say there are some features in here that could overlap reactive a little bit, but there's not really a good reason for it. There's a little bit of chronic inflammation in here, but I don't see neutrophils in the epithelium. It's relatively regular in thickness. I don't see big, nucleoli or mitotic activity out of proportion to the cytologic abnormality and the hyperchromasia. So reactive, yeah, but you really want to flag things that are dysplastic as dysplastic, or at least atypical and suspicious, or can't rule it out. Like you really want to keep that in play rather than overcall something as reactive. Yeah. Okay. All right, let's do this one and then we'll move on. All right, here's another kind of superficial oral cavity biopsy here. I like this one's kind of cool because it looks like a mushroom cloud or something, doesn't it? It looks like exploding off of there. It's very hyperkeratotic. All right, what about this one? Mild, moderate, severe, reactive.
More than mild.
Okay, why?
The basal layer looks very jumbled, and it looks like there's some significant atypia.
Yeah. And is it sort of getting maybe halfway up? You know, if it does get the high up, then you can use that. But if it doesn't, that doesn't mean it's not progressing upward in grade, at least. Yeah. Here, I would say the basal layer, a couple thoughts. We don't really see the stroma, but we also don't see inflammation in the epithelium. Okay. And it's very abnormally hyperkeratotic. But you see the basal layer is quite expanded, and these are hyperchromatic, and they're just jumbly, right? And there's a big giant nucleus there and a multinucleated cells there. There's accentuation of the intercellular bridges and edema in there. And there's these densely pink cells kind of low down, like where they usually don't show up. So, but it's kind of getting into the middle third. If this is full thickness, which even if it's not, then it would be thicker and then it would be getting higher up. And even we're starting to see some bigger cells up. Okay. Not a lot of mitotic activity. So I probably would moderate this one and call it moderate parenthesis high grade. I wouldn't call it severe because we don't really have, again, it's ripped off, but you presume that it didn't just rip off the reedy and that's it. I think this is probably reflective that it doesn't have a lot. I mean, that's a little bit of rounded stuff there. But I don't quite have the architecture to get me to calling it, frankly, severe. But again, moderate has to be, if you two-tier it, you kind of have to go with moderate and high grade. Now, don't overreact to this stuff. Even if there were a lot of Candida in here, Candida is a tricky one. So Candida, it's the chicken or the egg with Candida. Some people think that it, can incite dysplasia and carcinoma. Others would say, well, it typically will colonize those abnormally hyperkeratotic and abnormal lesions, and you don't really know. Candida can cause reactive changes that can mimic dysplasia a little bit, but I've seen lots of dysplastic lesions with candidiasis on the top. Now here it's just bacteria just growing in that keratin, and that doesn't really mean anything, but okay.
So in terms of kind of the like acantholytic look, you think that's more artifactual in this case?
Hard to know.
Part of the dysplasia?
Maybe, but that's one of the features you'll see. It's in the Hankinson article, and others have talked about it. How if you start to see this space in between them, like you say, acantholysis or separation, that's a bad feature. So I don't like to see that. I'm not totally convinced that that's inherent to the process here, but I think it is a little bit. But yeah, I don't like to see that either. So that's another kind of somewhat worrisome feature, but it really matures up, right? This stuff's not particularly concerning. Okay, all right, let's skip around a bit here. Let's do this one.
Can I ask a quick question about that previous one?
Yeah.
Kind of with the first two together. So let's say we had the architecture of the first one you showed with the cytologic features of the second one, because I think the second one to me is like kind of the most straightforward dysplasia because it's flat, or like it's not a like the reedy aren't super abnormal. They're pretty flat. And so most of my diagnosis is this, like, is it bottom third? Is it middle third? Is it top third? But what gets me is if it has the architecture of the bulbous reedy, but it also has something like the cytology that looks like this, are those features then additive? Like, do I say, okay, well, that would be more likely to be severe dysplasia because now we have like the bulbous reedy pattern, or, I still don't have prominent mitotic activity, or, I don't have the atypia going to the top. So those are the situations where I find it very, very difficult. Like, how do I add these things together? Do I push it into the severe category?
Well, I think what you said at the beginning of that is, I mean, all the features are kind of additive on each other. So yeah, if you put this cytologic features and this degree of not maturing up relative to if you gave me some architectural features of abnormal kind of bulbous reedy down there, I definitely would make this severe. And again, we're guessing a little bit that this wasn't ripped off and is hiding the reedy that are actually bulbous, but that doesn't usually happen. They almost always separate mostly at the basal layer, and you can see this is at the basal layer, right? You can actually see the smoothness there. So yes, if the architecture here was more abnormal, I would definitely use that even with the maturation probably to get to severe. Okay?
Okay, thank you. That's helpful.
Yeah. I put a lot on the architecture, but it's not usually in isolation. But the architecture is really important. Okay, so we know where we are here, right? The oral tongue. Right? It's got mostly muscle. So this patient had dysplasia and had it actually resected. I find these challenging and also helpful in a way because you can kind of, like I like to play the game of you follow along the epithelium and you go, normal, mild dysplasia, moderate dysplasia, severe dysplasia, normal, back to mild, and kind of, anyway. So we kind of do that when we're looking at these, and I do that in my mind. So a couple things. Why is it dysplastic? Reedy pattern's abnormal. It's a little bit bulbous, but not like striking. It matures up quite a bit, but it's hyperkeratotic. Okay, this is lateral tongue. Okay, and so on lateral tongue, we expect the epithelium to be relatively thin and not a lot of action with the reedy. And here, look at the keratin. Right, this is very abnormal keratin, extremely thick keratin for the lateral tongue. Okay, but so like in here, and that's extremely thick. Okay. And you can see the larger nuclei at the base and a little bit of, abnormal reedy. I never like to see them cut like this, but there's no stromal reaction to this. But it's getting a little busy in the base there. Okay. But these are not like really good teardrop reedy in the sense that they're dark and that one is, but it's not as, they're still kind of pinker in there. But so we'll have to figure out how we're going to grade this. But it's helpful as you come along to kind of like, follow it along and go from one end to the other. Let me see. Let's look on this one. Okay. So what about in here? Anybody got a grade in here for the dysplasia? Or is it not dysplastic?
I feel like this area that your mouse is on might be mild because the nuclei are a little multi-layered and a little more
a little prominent, right? Yeah. But
then
it doesn't
looks
really
like it might taper off.
Yeah, and it matures up pretty well. And they're not that large or busy down here. Not a lot of proliferation. Okay. But there's some a lot of hyperkeratosis, but there's some architecture. See, like Esther, this is concerning, but it's not blue and like really classic teardroppy. So I wouldn't overinterpret that and call that, oh, this is a keratinizing severe dysplasia, because it's not as well developed. But obviously there's a spectrum with all of these things. But now it's mild or low grade. Okay. So it's a good example to see it. Now, it starts to get, here I still think you're okay, but then you start to get this stuff, right? This is the worrisome stuff right here. All right, it's starting to get super strandy and super separated. You're almost palisaded a little bit. This is not as blue, but it's very, very abnormal. It's starting to almost bud off, right? Now, I wouldn't call this invasive because there's no stromal reaction, but this, and you're going to go in here and look at the cells, they're pretty big and pretty hyperchromatic in here. You see that? So this to me is and there's not a lot of proliferation still. So that's kind of strange. There's a mitosis. But I don't like this. This is a scary pattern, and we see squamous cell carcinoma falling off of this kind of precancer stuff all the time. And then it comes back to probably mild over here. Okay, but then it starts to kick in a little bit. So this one's a tricky one, but this one I would say is a keratinizing dysplasia that reaches in the middle. I think you'd have to call this severe dysplasia. So I'd probably call this one like moderate to severe keratinizing dysplasia, negative for invasion. Okay. And then try to see how much extended to the margins and stuff. So this one's tricky because it's like most of it is kind of banal, and then you get these areas, where it does this stuff. And you'd probably get different answers about how to grade this, but most of that would be mild, maybe moderate in there. And then I think you just have to go to severe here when you start to see this. Okay?
Do you mind if I ask a quick question?
Yeah, it's fine.
Sorry, I'm one of the first-year residents. Nice to meet you.
Hi.
Thanks for chatting with us.
Yeah, I'm glad to do it.
As I was looking around, and you kind of commented on this, so I just wanted to make sure I'm taking away a key point. You were saying, you could interpret some of these little islands below as potentially thinking, oh, is this invading from the epithelium down to the stroma? But you said you would expect to see more of a reaction. Is that like a desmoplastic reaction? Inflammatory
the
cells?
stroma.
Is that what you're talking about?
You'd like to see the stroma change. The other thing that it doesn't do is you often see aberrant maturation where the invasive stuff actually keratinizes even more, and that's helpful. But like if I look at all of these and I say, well, you could have taken and cut through the reedy of an adjacent reedy and cut it in a certain plane and it would look exactly like that, then I wouldn't call it invasive. Now, is this suspicious and worrisome? Yeah, and I'm going to look closely here. I might level this and make sure. But anyway, okay. But this is the kind of busy architecture at the base that you just have to pay attention to, no matter how much maturing squamous is over the top. Okay. All right. Anybody know where we're coming from here anatomically? It's oral cavity again. Anyways, that's the sublingual gland. Okay, it's all mucus cells. So this patient had floor of mouth dysplasia and had a surgical resection. How do I want to grade this one?
Severe.
Good. Yes, it's another keratinizing severe. Now, what would I do in here? Maybe mild. Maybe moderate there. And then it starts to do this, right? This is the scary stuff. And so you often see this like very pink, very far down. I mean, there's almost no basal layer here. I mean, you can see intercellular bridges all the way down. Okay. Mitosis, mitosis, mitosis. You see this edema looking pattern with the accentuation of the intercellular bridges. The maturation here is completely screwed up. Okay. So instead of maturing way up here, the cells are maturing way down here. Okay. So that's almost a reverse maturation pattern. Like sometimes they're not maturing as they get bigger and move up, and sometimes they are maturing way down low where they shouldn't be. So both of those can be used. Now you see the inflammatory infiltrate? If it's just lymphocytes, then I always worry more. People say, oh my gosh, that's inflamed. You should worry about reactive. And I say inflamed, you should, but if it's just lymphocytes, even if it looks like there's some exocytosis and dyskeratosis, that happens a little bit. You have to think about things like oral lichen planus, but that's not a dysplastic lesion, and this is overtly dysplastic. So lots of dysplasias get a lichenoid inflammatory infiltrate. If it's just lymphocytes, and particularly if there's not a lot of dyskeratosis, this one has it, but most of them don't, and that's often a feature that makes me worry more about dysplasia and not less. If there are neutrophils, granulation tissue, ulceration, then I'm more in the reactive camp, okay? Or if it has the clinical and other features of oral lichen planus, and I'm not sure it's even dysplastic, then you'd consider that. But see the hyperkeratosis, like here, you'd probably call that mild or low grade, okay? So, and this often happens with keratinizing dysplasias, where again, here, you're starting to get busy bulbous reedy. It's probably, is this high grade? Probably call that moderate or / high grade there. Let me see if I find another area. But this area in particular is quite worrisome. And I think down here, let's see. Yeah, here's another area down here where you're probably mild to moderate, pushing severe. So anyway, and like here, you get really like very abnormal reedy that are very, and then you kind of come back to mild, and almost at some point you're starting to get to normal, right? Because the basal layer is extremely tiny in here. You probably leave that as normal. See that? Okay. I don't know if this is helpful, but we kind of work through them. The other thing they can do is they can involve the salivary ducts. Okay, this is not a really florid example, but it does track a little bit down into the salivary ducts. And sometimes that can be kind of confusing because you can get these rounded collections of dysplastic epithelium that are way down below where they normally would be, but that might just be it tracking down the ducts. All right, let's go back.
I have a quick question, just to take your. Do you ever use like KI67 to help you out in this situations?
No, because I don't know what to do with it. I don't know what cutoffs to use, and they're not really been established. So the tools we have are our eyeballs, our brain, our microscope, and our books online and print. But there's really not tools otherwise. Immunohistochemistry levels sometimes. Okay. All right, another lateral tongue resection for leukoplakia. See it, which is white patch, is what this hyperkeratotic stuff's going to be. And again, we got a range of kind of things. This is too thick. There's some hyperchromasia, but this would probably be mild or low grade. See if it makes it anymore. Hold on, let me see if it makes it. Sorry, I'm just trying to track around here. They're very thick, right? Like very thick, but maturing up a lot. This stuff's not architecturally that abnormal. Mitoses, when they say mitoses should be really basal and parabasal. So in a well-oriented epithelium, if you start to see mitoses up high, that's a feature of dysplasia. It's not an absolute, but it's something that you typically see as a dysplastic phenomenon. So this one, and then kind of peters out a little bit here. So this one, I don't see anything I would call, it's a bit busy there, anything I would call severe, but it's kind of, it's pushing it a bit. So probably, but again, does it get to moderate? I think so, because architecturally it gets a little bit busy with the reedy pattern and the maturation. Like I don't like areas like this. So I might hedge a little bit here and call this mild to moderate. It's kind of tricky. Let's see if we can find another one here. All right. Flip it over. All right, what about this one? How are we doing? 11:45. A few more minutes. Anybody got
Moderate.
A grade for that? Moderate. Why?
There's some architectural atypia, and the basal layer looks a little expanded and hyperchromatic, but it's also tangentially cut, and there's this prolific lymphocytic response.
Okay. And this is a gingiva, so the reedy tend to be kind of interconnecting in a way that leaves these gaps. But you're right, it is a little bit tangential. So you got to be careful in tangential, because sometimes it'll make it look worse than it is, and sometimes it'll make it look better. So I would say I don't see a lot of hyperkeratosis. There's some, but it's a little bit torn off. This looks almost palisaded a little bit, but the nuclei are not all that huge. I mean, they're larger than you might expect. I don't see a lot of mitotic activity. There's some there. There's not a lot above, and it matures up pretty well. So this one I probably would make low grade, because it just doesn't, these aren't really that bulbous or really prominent. I think it's a good example, though, of palisading along the basal layer as a nice low power feature to let you know it's dysplastic. Now there's inflammation, right? But it's not causing a lot of lichenoid type. It's kind of hugging, but there's some plasma cells, and we don't see a lot of dying cells and a lot of exocytosis in the epithelium. Let me show you something real quick. Now, oral lichen planus. Okay, that's something that can give you hyperkeratosis reactive and give you a lichenoid inflammatory infiltrate and can somewhat mimic dysplasia, but it has a very typical clinical. So this is oral lichen planus, okay? It's buccal mucosa, okay? And there's this dense, they call it hugging like moss on a rock or lichen, okay? You can see the exocytosis, so it's really attacking the epithelium. You'll look around and you'll start to see dyskeratotic cells here and there. Okay, it's very hyperkeratotic. It even has a prominent granular layer, which is abnormal. But it's not super architectural. It's actually pretty flat. Now here you might wonder a little bit about dysplasia, but then you see kind of open chromatin and prominent nucleoli in there. And oh, by the way, this patient had white patches on their tongue and on both inside of both cheeks. They had a clinical that was very lichen planus and not like an isolated leukoplakic lesion. So this is actually oral lichen planus. Okay, it's the same pattern that you see in lichenoid inflammation in dysplasias. It's just usually more florid, and the architectural and cytologic changes are not the same. Okay, and people say, oh, you can get dysplasia arising out of lichen planus. Yeah, but if you've got a dysplastic lesion with a lichenoid inflammatory infiltrate, be careful with calling it lichen planus because it's probably actually a dysplasia. Okay, so let's do a few more. Let's do some easier ones. Trying to show you the normal up here. Normal. Yeah. Normal, and then poof. Subtle, right? Okay,
very
now this,
subtle.
Yeah, very subtle, right? Very subtle. Okay, so this one, like, no one would have a hard time to know that this is precancer, right? Like, and bad. So this is one where I might say squamous cell carcinoma in situ. I mean, this thing is just thick, super bulbous. Look at these bulbous reedy, teardrop reedy. Everything is abnormal, right? There's no maturation. This just looks like it's cancer waiting to spill out. And so you look closely for invasion. But I would probably call that squamous cell carcinoma in situ. Why? Because I just want to, it's bulbous and scary. It's just scary, right? And so I want to just give it bells and whistles, as they may say. So this is one where I might, if it's full thickness, expanding the epithelium, it looks basically like squamous cell carcinoma waiting to fall out of the epithelium, then I will use that terminology. But I don't use it often. Okay. Here's another one. Again, not subtle. This is one. Okay, not subtle, right? Just so you can see all the features. All right, let's do a couple more. We'll stop. I do want to show you an example of something that's kind of cool and unique and a little confusing. We'll do that last. We'll do that after this one. All right, what about this one?
This one is kind of, I guess, just to give a guess, I would say moderate dysplasia. Okay. If I could pick maybe moderate to high. I feel like the basal layer is kind of thicker than I'd want it to be. Definitely almost halfway up. Yeah, and you can kind of see some of the reedy, or I'm sorry, the intercellular bridges between cells, and then
prominent.
Some parakeratosis and hyperkeratosis, and even just the basal layers. There's maybe a little bit of cellular atypia in a way that I don't like.
Good. Yeah, the nuclei are quite large down here. Not a lot of mitotic actin. There's some. Not a lot of acantholysis, if you will. So I would say this is where, if you're doing a binary system, this is where I'm going to back down a little bit. Whereas I might just throw this as moderate all the way through my career. If moderate is high grade, and I'm not sure this is what I would consider a high grade lesion. Now, where does it stop maturing? Well, like I would say there's a lot of pink cytoplasm in these, like when do you say, is this 50%? You know, like, so I guess I would lean, and the architecture is not particularly scary down here. So this is one of these to me that's kind of a tweener lesion, which is why I think 3-tiered is better than 2-tiered. But I probably would call this mild because I'm not convinced that it's really got all of the features I'd like to see to get it up to something to call moderate and to actually have it lumped in with high grade. But it's, this is the art more than the science, right?
What about the edge there on that part that looks more hyperchromatic?
Over here or over here?
On the other side, yeah, there.
It's ripped off.
Oh, okay.
See, it got torn off. So there it's partial. That's the problem. You don't have the surface there.
It just looks like a little more.
It's a rip off. See, it's ripped off. But I know, yeah.
Jumbled and.
It does. But again, but does it have bulbous reedy, and is it really?
Yeah.
Yeah, you just can't tell for sure. But it might be a reason maybe to hedge towards and call it moderate then. Or get levels, right? This is one I would probably level through. I can't do that with these, but okay, let me show you guys something else. This is kind of a cool one. This is a patient with a big old white patch on his ventral tongue and floor of mouth. He's a heavy smoker, older male. Okay. All right. How about that one? Bad. Bad, right? It's bad. Dense parakeratosis, very little maturation, very roller coaster reedy, okay? Now, if you come back to low power, what you kind of see is that it's blue, especially over here, it gets really blue. Like this looks like, to me, like VIN3 is what this reminds me of. I don't do GYN pathology anymore, but this looks like VIN3. Very blue. And look at all the multinucleation. There's all these apoptotic bodies in here. See these kinds of things. There's these things that they call mitosoid karyorectic debris, where they look like mitoses, but they're actually just degenerated cells. Hold on. All right. Now, does anybody know why I'm showing you this? Other than it's severe dysplasia carcinoma in situ. Okay, well, this is HPV-associated oral dysplasia, okay? It tends to give tons of apoptosis, mitosis, usually looks very blue, dense parakeratosis. It is a very high predilection for the ventral tongue and floor of mouth. And so this is a transcriptionally active high-risk HPV-related dysplasia. That happens here and there. This is the one consistent clinical scenario where you see the parakeratosis. It's very typical. Dense, kind of darkly pink parakeratosis, very typical. And then these mitosoid kind of karyorectic bodies in here. So we had a bit of an argument in the editorial board meeting about whether or not we should make this a distinct form of dysplasia. I think the literature and the morphology is quite clear, but the clinical significance is not very well established. Whether it's HPV associated or not, well, who really cares? It's, severe dysplasia carcinoma in situ, and they need to be treated and followed. And what's the progression risk for HEV-associated dysplasia, grade for grade versus conventional, non-HEV-associated oral dysplasia? Well, that's not well worked out, but the WHO, we got kind of vetoed out, and this is a distinct form of oral dysplasia. So when you see this, you're supposed to test it and actually establish HPV. So you can P16 it. It should be extensive except for the keratin. And then I would do RNA in situ hybridization. We have it and just confirm that. The other thing is you sometimes see cancers associated with this dysplasia in the oral cavity that are non-keratinizing and look like tonsil squamous cell carcinomas. Will often have this stuff around them. And so you can get truly HEV-associated oral cavity squamous cells, particularly ventral tongue floor of mouth. But again, in this you would test. If you don't have invasion, you're supposed to test, which I kind of am frustrated by. But I think the data about what it means and how to manage it clinically will probably come when we actually are recognizing it consistently in clinical practice. But if there's invasive HEV-associated oral cavity squamous cell, there's no evidence that those patients do better. So you may see it, and it may look very HPV in the ventral tongue floor of mouth, totally distinct and away from the oropharynx. But those patients are almost always older men, heavy smoking, with big tumors. So there's no evidence, and there's no evidence that they're prognostically favorable. But they certainly have the morphology occasionally. But this is HEV-associated oral dysplasia, and right now you're supposed to grade it basically with the same criteria that you grade every other oral dysplasia. So this obviously would be, I'd call this carcinoma in situ. But anyway, it's just a pretty example. See how blue it is? It's so blue. Then we come back to the normal over here.
How do you top line this one?
HPV-associated squamous cell carcinoma in situ, because I would test it. I mean, you're stuck with it. I kind of feel like the terminology, it's a distinct entity. But anyway, this is so typical of what it looks like. When you see these, if you see one of these in the future. The other thing is sometimes patients will come for oral cavity surgery, and you'll see tons of this stuff in the margin. I remember Lauren Dehan had a Frozen's one day on an oral cavity squamous cell carcinoma patient, and they were all just full of this blue full thickness stuff. And the clinical folks were like, wow, we don't see much clinically. This looks like relatively normal mucosa. And all the margins had severe dysplasia. And she said, Dr. Lewis, it looked very much like it was going to be an HPV-associated oral dysplasia. Anyway, so keep it in mind. Now, this one's blue and doesn't really mature. You don't see that in oral dysplasias that often, but it's not flat, right? It's very bulbous and very architecturally abnormal. And so when you do see blue, non-maturing at all dysplasias in the head and neck, they virtually never are perfectly flat mucosa. They're usually architecturally like this. Okay? We are at noon. Well, it's noon, 2 o'clock your time.
Dr. Lewis, yeah. If this is not too much to ask, would I be able to show you a oral cavity question dysplasia case that we just so happen to get today?
Okay, sure. Let me stop sharing.
If no one else has any questions or anything like that, I don't want to interrupt anyone.
Can I ask a quick question? So some of these, if I'm like on the fence between, is this truly a mild dysplasia? Is it a reactive condition? I'll sign it out descriptively, like thickened squamous mucosa with overlying hyperkeratosis, no significant cytologic atypia, and then write like a reactive condition is favored, but a mild dysplasia cannot be ruled out or something like that. Is that just not helpful at all? Or like, do you ever sign anything out like that? Or should you really try to get down on one side or the other?
I mean, you should try, but there just are some times where it's just really tough to know. Having looked at squamous lesions for 20 plus years, sometimes you're just like, I don't know. And if I'm more on the suspicious side, I will say suspicious for dysplasia. And if I'm just not sure, or I favor it's reactive, but I just can't say for sure, then I'll do like you just said. I'll at least try to favor something in the comment.
Okay.
Particularly, sometimes they can just watch the patient. I mean, dysplastic things don't go away. So, observation will be really important in those patients. But if I don't know, then I'm careful not to close the door on it if I'm kind of on the fence and not sure.
Okay. Sorry, Connor. Go ahead. I just thought I'd ask quickly while you get that set up.
If you want to remember dysplasia, you can say dis ain't good. That's the way I like to think about it. Anyway, dis is bad.